Okay, I'll let Bill have all the time he needs. So another talk about the international patient summary and looking at WA Verify. So Bill, go ahead.
Yeah, thank you. And Rob mentioned grabbing slides from several different people. I think my talk follows naturally on him. I saw a slide that he showed that I wish I had thought to grab, so this all worked out great. But as I said, I think before the camera started, the slides are up there at that link, and they'll remain at that link. I'm a professor at the University of Washington. I work very closely with Department of Health in Washington State through an interagency agreement. And DOH has been, and anyway, let me just go on and say, the other thing that you'll see throughout, I heard Rob mention the Argentina-developed patient IPS viewer. And you'll see bits and pieces in what we show of lots of work that others have done. And like at this point, the attribution is kind of diffuse and hard to find anymore, but we've built on Josh's core smart health links activities. We've built on the work that people have done in IPS. And so we're grateful for all of that, even though it's hard to remember all the people that we need to thank. 3 things I want to do, brief bit of background. Mostly I want to show what we're working on. And then I want to tell you what I think are the hard problems and see what kind of advice folks have. Public health, because so many people here are not from the US, I can say that, as I'm sure you've observed, public health has had a difficult time in the US in the last few years, but some good things have come out of COVID, and in some areas we've managed to build public trust and to experiment with providing services from public health that we haven't traditionally done in this country. So one of the things we did that was very successful in Washington State and several other states in the country was smart card-based vaccine verification. I think James might have mentioned that yesterday in his talk briefly. In Washington State, we had 2 million people out of our 7 million population. We're grateful for something the government did to make it easier to get their information. We did a bunch of kind of outreach and survey work on top of that, and we found like a number of other things that people in Washington State were interested in having public health make easier for them to access. The pathway for them to get immunization data more broadly is there, but it's not all that convenient to use. They were interested in having emergency health data for emergency care visits outside their normal care network. They're interested in having health data to facilitate travel. There are a variety of different topics. And so what we're trying to do really is build on an application called WA Verify, which provided verifiable vaccination records using smart health cards. What we've done is develop WA Verify Plus, which serves a much larger set of health data, makes a much larger set of health data available to people using the IPS standard and using smart health links. And so, again, I think people will have seen yesterday this drawing, what comprises the IPS, and so forth. We are doing this as a state partner in the Global Digital Health Partnership. That is a group of countries rather than states or provinces. And in the US, the Office of the National Coordinator of Health IT is our national delegate to that group, but we are very closely involved in trying to demonstrate the GDHP's value proposition around IPS within the US. Bryant Karras at Department of Health is going to be here Thursday and leads a lot of that work. And he'll be talking with Matt Ram from ONC and with Isaac Vetter from EPIC on a panel. So that will be good. These are slides from him, so they're a little bit out of date, but they are the partnership slide. I wanted to mention, the problem with mentioning any countries is that there are other countries that you don't mention, but I like New Zealand's flag, and I met my wife in New Zealand, so I thought I would mention that New Zealand is very active in IPS work. And then because we're in Washington State, we're very interested in Canada. And I think one piece of interesting concrete news around Canada is not only is there a national initiative around specifying the IPS, but several provinces have developed their, as happens in Canada, have developed their own provincial flavors, their own provincial projects around use of IPS. And New Brunswick is apparently still slated to go live with production IPS on July 15th, so coming right up. That's exciting. 5 minutes of background, and so I want to move on to what we're doing. There are some screenshots here, but I'm going to try and skip the screenshots and go directly to this QR code is the application that I'll show you, and I'll put this back up afterwards, but you're welcome to look now. The little GitHub thing there is just a reminder to me to point out that the code's all open source, and on the application website, there's a GitHub link down at the bottom, so people are welcome to look at this. I think I've heard informally that our code has been useful to other people, and we're happy to have it be so. Let me get out of this and find a browser. So this is what that QR code will take you to, is a demonstration site. We ask that you not use it with real health information, but that would be up to whoever uses it. I have used it with real health information, so for whatever that's worth. The process of, let me take a quick look. We have kind of a advanced features mode and a simpler mode. I'm going to kind of walk through the simpler mode, but the basic idea is to be able to retrieve a set of health data using what in the US is called the 21st Century Cures Act. We have a right to get an electronic copy of our data, and these three options walk you through the workflows for retrieving a US Core data set from Epic's Sandbox, from Cerner Sandbox, and from Smart Health IT Sandbox. I should point out, I guess, that if we bring up there's a variety of other strategies that we can use, like directly loading from URLs if you're interested in poking around at this, uploading a FHIR bundle directly, or this is something we showed at HIMSS, was doing an individual patient access mediated TEFCA query. So this is stuff that I'm happy to tell you more about why I think this is important if at question time. But let me just go back to the simpler model and say, in fact, the simplest possible model is let's just load a quick sample of data. And this brings us to a separate step, which is we've loaded a bunch of data about the patient. Now, what might we want to do with that? And so we might want to pull up a second IPS from another provider. I'm not going to claim that we've solved the problem of combining data from multiple sources very well, but it is definitely something that we want to sort of think through and demonstrate and work on. We might want to have the patient enter information which they know about, which their healthcare organization might not know about very well, but things that are relevant to their health, where they work, where they've worked previously, have they worked in a combat zone, have they been exposed to chemicals? That's obviously, kind of been a very hot topic in the last couple of years. Let me just clean these fields up a little bit. And then advanced directives is an area that Rob mentioned that several new elements of the IPS or that there are several ways in which people are extending the IPS. There is no occupational information, but we work a lot with NIOSH, one of the federal agencies who cares a lot about occupation, so we're interested in extending it that way. There is room currently in the IPS for advanced directives. We think that there's room to better express advanced directives, and so there's a group of us who are kind of actively working on trying to do that. This particular demonstration was around pulling advanced directive data from a FHIR server, either ours or another one. And I'm just going to kind of not do all that because you're welcome to poke around with it all you want. And then finally, this section is here to represent that there are a bunch of complex questions around editing the IPS, and I'll kind of come back and frame those in the discussion section a little bit. But we have built the simplest of possible editing options, which is if you see something in your medical summary which is not correct, you don't have to report that as part of your medical summary. And I want to come back to that because, you know, James yesterday alluded to the notion that there are lots of different summaries that are appropriate for different settings. I could spend the rest of the 10 minutes talking about that right now, and so I'm not going to. I'm just going to say, let me go ahead and create a Smart Health link. And there are things that I could have done on that screen, like make that Smart Health link time limited. I can assign a passcode for that Smart Health link. I may forget to mention this elsewhere. So Rob showed an interesting screen that showed some kind of, not branding, but some sort of messing around that we've done to try and convey visually the content of a QR code, because there's so darn many QR codes in front of us these days. And, you know, so this is what we've settled on for the kind of, let me call it the demo of the day, as it were, was we decided we want to start branding these things with a consistent use of the fact that they are Smart Health links, and we want to brand them with the fact that it's an IPS, that means it's a health summary, because not everybody knows what the logo means, and that it came from Verify Plus. So our model is that this whole thing is the image that you might copy and paste to somebody. This is the image that you might put in your Apple Note on your phone to show somebody. This is the thing that might eventually make it into the Apple Wallet. So Rob had an example that showed a locked and unlocked icon in the middle of the QR code. And that's another thing we're interested in signaling in advance. Are you going to need more information to get into this QR code, or is it open to any physician, any family member who might want to access it? The last thing I want to show you is the viewer. And so again, this will look vaguely Argentinian to those of you who remember this Argentinian original viewer. But we display the IPS, we display the IPS, and as James pointed out yesterday, there is generated text as part of the IPS. That generated text is very important to make the IPS more human readable. We also are interested in whether we can more accurately, or whether we can better interpret the text. And you'll notice it's not actually changing. I'd like to pretend that wasn't the case, but we also have made a bunch of very last-minute changes to the viewer, and I think that this particular feature is broken. But next time you look at this, hopefully you'll see two very different ways of looking at the text representing the content of an IPS. I think that really the final thing that I wanted to do, we have 8 minutes left, and that is plenty of time for me to go back and say, yep, this is who I am. I'm going to show this slide again. The interesting thing about QR codes is that they are artifacts. And one of the things that we've experimented a little bit in Washington State is printing out cards for people with that artifact on it. So it isn't just a matter of whipping out your phone and showing a provider your QR code and hoping they scan it and follow it through, but we think this notion of actually having an artifact with a semi-permanent QR code is a useful thing. There's a whole philosophic debate about whether the IPS should change in the background or whether it should represent a static artifact. And again, more on that. So this is my page of things to talk about, or things that we think about. One is this whole notion of patient-controlled. Rob alluded to some of the real advantages of that, the fact that 21st Century Cures Act, that TEFCA's individual access services provide people, at least in the US, with a right to getting copies of their data. Different countries have or don't have kind of corresponding abilities. We're very interested in letting patient-directed activities be driven by terms of use rather than by healthcare organizations, you know, using HIPAA as a shield and saying, you know, privacy laws allow it, you know, say that we can't give you your data. That's obviously not the case anymore, but there's a lot of ways in which organizations erect barriers. We're interested in equity and access, and those are kind of terms that have a lot of meaning in the US. But I think that there's some very basic development concepts around health literacy, usability, this notion of like, is this just like, what does this QR code mean, that are all sort of very important. The idea of government doing this requires a little bit of a shift in policy from what our state government currently does, and we're navigating that. We're not sure about sustainability. I kind of touched on the idea that curation is important, and I heard somebody ask a question earlier about, is this the doctor's language or is this the patient's language? I think within this room, I can think of two people who would give you very different views of that. And then I think there's hard problems like James characterized the IPS yesterday as a summary that contains the pertinent data for unplanned care. I used to practice emergency medicine, and the word pertinent is incredibly context sensitive depending on who the patient is, why they're there, and that's just for an emergency department provider. So I think that just saying pertinent data for unplanned care doesn't quite narrow what we need to do well enough. Multiple data sources, the issue of creating profiles versus editing, I think, is kind of a fascinating one. And I guess I would wind up with, this issue of whose voice is it in the IPS and of the different cultural assumptions that we have around, like, is a doctor the one who says true things about the patient, or is the patient the one who says true things about the patient? And what matters to somebody else in taking care of a patient? What matters to a patient in expressing their own history and so forth? 4 minutes for questions, comments, please. Oh, I'm sorry, I should say, please don't say anything until the microphone has arrived.
Right, thanks for that presentation. How do you actually propose that we deal with different iteration of IPS? Like, let's say Washington have their own QR code, New York, Canada, whatever the case is. Shouldn't they all be, landing in one IPS model? Like, how do you deal between the different iteration? Because to your point, maybe the patient wants to add certain information that's not necessarily part of another QR code. So how does that best practice look like in your opinion?
So the QR code itself is the smart health links side of things. And the fact that the smart health link resolves to a viewer, which can view IPS or many other things, that is the consistency with the smart health, with the QR code. So that part of it to me seems like it's a little less important. The IPSs can be consumed electronically in theory. It's just a FHIR bundle, but nobody's doing that yet. There isn't an EHR which is just going to sort of suck in an IPS and say, great. So, we require that the provider use only the EHR, and therefore we're going to stick this IPS in the EHR. So I'm a little bit less worried about consistency, like everybody has to read the same IPS. I think there is a core set of data, which is the ISO 27269. ISO 27269 specification of what a patient summary has to have and what it can have. We're really interested in making the IPS in Washington State reflect what it is that Washington State residents want to use. And advanced directives are one of the things that they told us that they want to use. Our state has a series of legislation they just enacted around resuscitation orders. And so the part of the advanced directives that we're really interested in are these publicly available resuscitation orders or publicly transportable resuscitation orders. So I think that like most things, it's the core that should be in common so people know what to expect. It's the mechanism of accessing it that needs to be in common, but we really at this point need to be sensitive to all of the variations which are going to matter. I think the work around the Hajj is kind of fascinating because that's a real test of what do you need for that sort of single episode immediate care in languages that we're not used to in the US and with cultural assumptions that we're not used to in the US. So it'll be kind of fascinating to see how that plays out.
This has been awesome. Wondering about chain of custody and the signatures and things. So how does Well-Verify think about if I include, for instance, my vaccination record within a larger IPS, that the link then is signed for the larger IPS?
Yeah.
What do you guys think about chain of custody?
So there's a mechanism for verifiable health information, right? Verifiable clinical information, which is part of this, what we can attest to as a state is that we are that we can verify that the information has been unchanged since the patient retrieved it and stored it with us and asked us to create an IPS out of it. We can't verify that the information is necessarily accurate. For the data that comes from the state immunization registry, we believe that data is accurate because it's state data. For data that comes from the healthcare organization, we can't attest that they have all your diagnoses correct, or that we certainly can't attest that it's complete because the patient may have decided for some particular travel setting or whatever that they won't have listed some of their diagnoses. But we do want to be able to attest that the thing we got from the healthcare organization is being passed through correctly. For things like occupational history or advanced directive, that's really the patient's voice. And what we want to be able to attest there is that the patient gave us that information. We can't say that their durable power of attorney for healthcare is accurate, but we can say this is what they told us and this is when they told it to us. So I think that mixed provenance is what actually happens in the real world, and we're better off trying to surface it and emulate it than we are trying to pretend that it's accurate just because it's in the computer.
So would you carry the immunization signature? Sorry. So would you carry the immunization signature forward within the larger bundle as well?
That's what I would like to do, is to carry the immunization signature for the immunization section. I don't know what happens if Providence Hospital says that I've had immunizations that the state doesn't say I have. And actually, my case is a good one. I've had some COVID immunizations in Massachusetts that don't show up in the state registry, but those really are me. And so presumably those would be things that I would attest to, or Walgreens would attest to, or, but I think that has to be carried through. Probably not surfaced in big letters as more important than the data itself, but it probably does need to be findable. I know we're at time.
Okay, well, we're out of time, but of course, anyone can still talk to Bill while he's here. So
Yeah.
Thank you so much for an interesting presentation, Bill.
Thank you.